So these are data from the CDC, and what it shows is that over the last decade, the mortality and the burden of disease related to hepatitis C continues to grow, while we're making progress with HIV. Hepatitis C, in terms of chronic viral illnesses, is becoming a larger burden on the healthcare for the society in the US. And this has really been a major driver for the Institute of Medicine report on viral hepatitis. And it has really pushed the envelope in terms of development of new therapeutics. So it has also led to some new guidelines, which there is increasing acceptance from the US Preventive Health Task Force, which has now upgraded this to a level B recommendation from a level C. And essentially, in primary care, there is now a recommendation based on prevalence that baby boomers, that is people who were born between 1945 and 65, should at least one time be evaluated with a hepatitis C antibody test. And if they're positive, they should be then referred for treatment. At ages, those born after 65, it should be based on risk factors. And this is really, these CDC guidelines are based on prevalence in these different age groups and the contribution to their burden of disease. The fact that we have highly sensitive diagnostic tests with over 90% sensitivity and specificity, and very effective therapy that is now available. And clear demonstration now that treatment actually reduces mortality and morbidity. And what I want to share with you today, the bulk of my talk, will be on the emerging trends in the therapeutics of hepatitis C, which is beginning to look more and more like HIV treatment with the number of combinations that are available. But to also share with you how often we can actually get rid of this virus. And this is a virus where we actually use the word cure. And that is remarkable because, as you know, we do not cure HIV, we do not cure hepatitis B, we do not cure many other chronic viral illnesses, mononucleosis, CMV, but we do cure hepatitis C. And this is a remarkable story in the entire history of medicine, of the human race, that I'm going to share with you. So just to give you a historical perspective of how dramatic this story has been, is that it's really barely 25 years since we started with the discovery of the virus. And there was a almost empirical study of interferon, and it was found that some people who received interferon, their liver enzymes got better. From that initial observation in the early 90s, there was another empiric addition of ribavirin because it was supposed to be an antiviral drug. Nobody understood how it worked. We still don't understand how it worked. But then moving through combinations of interferon and ribavirin, then pegylation of interferon so that you could only take a shot once a week. And then around 2010, the discovery of, and actually the approval of directly acting antivirals, which is really a tour de force of molecular and translational medicine. Because how this happened is that the virus was discovered. Over 10 years, from 1990 to 2000, the structure of the virus was clarified. Based on the structure, the key proteins that were involved in viral replication were identified. Through high throughput screening, thousands of compounds were developed against each of the proteins. Toxicity screening was done to narrow that list down, and then eventually these were taken forward into clinical trials. And now in 2015, we got rid of interferon, as I will show you. We got rid of ribavirin, and we can now essentially cure the virus with one pill once a day for 8 to 12 weeks, as I will show you. And so the number of drugs that are now becoming approved for hepatitis C, every year we're seeing an increasing number. And it's getting harder and harder to keep up with these drugs, especially since many of them are unpronounceable. So let me give you a little simple clue as to how to keep track of these drugs. So the protease inhibitors, so there are three different targets, as the NS3 target, the NS5A, which is involved in cell replication, as is shown up there, and the NS5B, which is the viral polymerase. So the NS3A is a protease. So all the protease inhibitors start with a PRE, end with a PRE-VIR, Previr. So if it ends with a Previr, it's PR protease, NS3. If it is a NS5A inhibitor, it always ends with a ASVIR, so ASVIR. So if it ends with the ASVIR, A stands for NS5A. And if it inhibits NS5B, then it always ends with BUVIR, B for NS5B. So that's the easy way to keep track of these. So the protease inhibitors are fairly high potency. They are multi-genotypic. That is, they can attack HCV virus of various genotypes. And they have an intermediate barrier to resistance. The 5A also are highly potent. They're multi-genotypic and have a low barrier to resistance. Now, the 5Bs, they are two different types. You have the non-nucleoside inhibitors, and you have actual nucleotide inhibitors. But these also, particularly the nucleotide inhibitors, are pangenotypic and have a high barrier to resistance. So if you think about the hepatitis C virus, we know that there are 6 major, although there are now a couple of additional genotypes, but there's 6 major viral genotypes. And the epidemiology of the virus is different in different parts of the world. In the US, genotype 1 accounts for 80%, and 2 and 3 and a smattering of rest accounts for the rest. And so if you look at what is currently approved and what is recommended, it's sort of a matrix where you have different regimens approved for genotype 1, 2, 3, 4, 5, and 6. And this changes. At every few weeks, the recommendations shift based on new studies that come out. And this is a very fast evolving field. So personally, even as a hepatologist, I do not try to memorize all of this. What I do memorize is the little thing at the bottom, which is the www.hcvguidelines.org, which has a nice table. So if you do have a patient, you can pull that up, and it'll give you exactly today, on the day you're seeing the patient, what is the current recommendation, because it literally changes every few weeks. So it's impossible to try and it makes no sense to try and memorize all these permutations and combinations. And what I will do now is walk you through the evidence base, particularly focusing on the principal genotypes in the United States. So the main excitement is around this combination, which is a fixed dose combination, so it's in a single pill. It's called Sofosbuvir and ledipasvir. Sofosbuvir with a B in it, so it's an NS5B inhibitor. Ledipasvir has a asvir, so it's an NS5A inhibitor, so it's a combination of NS5A and NS5B inhibitor. The FDA has approved it principally for genotype 1, although the IDSA, which is the infectious disease, and the ASLD, the liver practice guideline, and the evidence base supports its use for treatment naive as well as treatment experienced, which is people who have previously received different types of hepatitis C treatment with genotype 1, 4, 5, and 6. The benefit, of course, is that this is a regimen that not only works for people who are treatment naive, but it also works for people who have previously received interferon-based therapies and failed interferon-based therapies. It gets rid of ribavirin for many patients. And so ribavirin, as you know, is associated with anemia, which can occasionally be very severe, requiring blood transfusions, and is a problem if you have any renal insufficiency because it's not dialyzable. It accumulates, causes severe anemia, and it also is teratogenic. And this regimen can also be used in people who actually have disease that has progressed all the way to decompensated cirrhosis. The only limitation that continues to remain in this population is that those who have chronic kidney disease, Sofosbuvir-based regimens are still a problem because of accumulation. So here's the evidence. So the way we assess cure is by something called sustained virologic response, or SVR. SVR means that you get treated for hepatitis C. The day you stop your treatment regimen, your virus is undetectable using the most sensitive PCR assay that we have. And then 6 months later, you're still virus negative. Now it turns out at 12 weeks, 12 weeks out from the end of treatment, if you're virus negative, that's called SVR 12. If it's 24 weeks, it's SVR 24. 12 is almost as good as SVR 24. And certainly those who get past the 6-month point, unless they reinfect themselves, you can actually legitimately use the word cure in those patients because they do not get their virus back. There is now 20-year follow-up, and their survival improves. So Sofosbuvir, ledipasvir, this shows genotype 1A, starting from left to right, 1B, people with low viral counts, that's in the ION-3 trial, and you can see the SVR rates are in the 94 to 97%. This is very dramatically different where we started in the early 90s, where our virus response rates were 5%. So we went from 5 to about 10, 12% with interferon and ribavirin, to with pegylated interferon to 25%, and then eventually with PEG ribavirin to about 30, 40%, with Boceprevir, telaprevir to about 70%, to now about 95 to 97%. So currently, any kind of therapy for hepatitis C, if you don't have over 90% cure rates, you're not in the game. You might as well put that drug away and burn it. So this on the right-hand side in the green bars is a different study. It's called the Sirius study. These are people who previously failed Boceprevir and telaprevir. These are the protease inhibitors that were introduced about 3-4 years ago. And again, you can see one pill once a day. In this study, from 12 to 24 weeks, cure rates 96 to 97%, showing that within 12 weeks, you can essentially get rid of the virus. Now, there are also some resistance-associated viral sequences, or RAVs, and these are particularly directed against the NS5A target within the hepatitis C virus. So the question is, if you have these, does this combination, does its efficacy decrease? So these are pooled analysis of phase 2 and 3 trials, and what you're seeing from left to right, again, is the SVR12 for 12 weeks, and you can see with and without ribavirin, essentially, it doesn't really make any difference. The response rates are right around 90 to 97%. And then at 24 weeks, that jumps to about 100%. So even in those who have resistance-associated viral sequences, these are very, very recent data presented at the European Liver Meeting, and essentially shows that this combination, even if you have the resistance-associated viral sequences, it doesn't really matter. You can overcome it, particularly if you go to 24 weeks. Now, there are a small subset of patients, because its response rate is 94, 95%, which means there are those rare patients, 4 or 5%, who fail. And so these are data that were published earlier this year. It's an open-label study of genotype 1, which is the most common genotype, treatment-experienced patients. Most of these patients previously received Sofosbuvir, interferon, and ribavirin. And what they received over here is Sofosbuvir, ledipasvir, and ribavirin for 12 weeks. And again, as you can see, 95% cure rate with just Sofosbuvir and ribavirin. And if you gave them PEG, riba, and Sofosbuvir, they got a 100% sustained virologic response. What about those who failed the combination, the Sofosbuvir, ledipasvir, what to do with them? So over here, this is another study that was just presented very recently. And over here, they got ledipasvir and Sofosbuvir for 6 months. So they failed the 12-week study. So now they got a more extended 24-week or 6-month duration. And this is a pretty tough group. This genotype 1A, which is a little harder to treat than genotype 1B. About half the patients were cirrhotic. About 80% of them had these resistance-associated virions when they were studied. And previously, they had either received 8 or 12 weeks of treatment. And as you can see over here, with ledipasvir and sofosbuvir with ribavirin in the middle column, you have an 82% response rate. And with this new compound, which is a protease inhibitor, without ribavirin, that's GS9669, you got an 88%. So you can rescue, even those who fail this, it's possible to rescue the bulk of them. Now on the right-hand side, there's a small number of patients who received ledipasvir, sofosbuvir with ribavirin for 12 weeks, and the response rates are much smaller. So the word of caution that there's still a little bit more work to be done. Now, we also see hepatitis C frequently in those who have HIV. And again, in the past, this used to be a big problem because those who had HIV really didn't respond and they didn't tolerate interferon-based therapies very well. But now we see over here with this current combination between 96 to 100% response rate, going from left to right, overall 96%, doesn't matter whether you're male or female, low virus count, high virus count, genotype 1A, 1B, genotype 4, African American, non-African American, you get a great response in all of these. So, we can, I think, actually say mission accomplished over here and mean it. So, African Americans has been a tough population to manage with interferon-based therapies historically. So if you just look at people who just have hepatitis C, not the HIV, and you look at 8 weeks versus 12 weeks versus 24 weeks of treatment, and these are studies, these are pooled data, where a majority of the patients were previously treatment naive, but there are also some studies where patients were treatment experienced. Some of them were cirrhotic, some were not. But if you look at the last 2 rows, you can see that the response rates vary from 91 to 100%. So once again, the bottom line is we have made tremendous progress with this combination, even in this tough population, which historically was very difficult to treat, had low response rates with interferon-based therapeutics. We can now cure the disease in 90 to 100% of patients. So African-American patients, don't hold back. If they have concomitant HIV, don't hold back on their treatment. We can actually cure just about all of these patients. Now, that's the good news. But there are some words of caution that you have to remember. First, that with Sofosbuvir, there are now about 3 cases that have been reported of symptomatic bradycardia, particularly when it has been specifically when patients are concomitantly taking amiodarone. And sinus node dysfunction accounted for 2, and the third one was a third-degree AV block that developed within 10 days of drug initiation. So it does affect amiodarone blood levels, and so needs to be taken into consideration. And the regimens with which this was associated was Sofosbuvir and Decompensated and Sof and Cimeprevir. So both had Sofosbuvir in it. So the other combination that has been approved by the FDA and is widely available are these 4-drug combination. So Paritaprevir, so it's a protease inhibitor, and it's boosted with ritonavir, so it gives you a higher blood level because it essentially affects the way the drug is metabolized. And along with ombetasvir, so it's a asvir, NS5A, and decabuvir, so it's a NS5B. So you got 5B, 5A, and protease inhibitor. So this has been approved by FDA for genotype 1 and 4. For 4 without decabuvir. And according to the combined practice guidelines, again, it's recommended for treatment-naive and treatment-experienced patients with genotype 1 and 4. The benefit is you have 3 different agents against 3 different targets, so it reduces resistance likelihood. Its use is supported by a very large development program, very big data set, so it's very, very evidence-based, including cirrhotic patients. The limitation, of course, is one limitation, besides having to take multiple pills, is that for genotype 1A, you also need ribavirin. So here's the data. Once again, there's no point trying to memorize each study, because the bottom line is they're all in the 90 to 100% range, and that's what I try to remember. So if you go through from left to right, the first two bars represent the Pearl 3 and 4 trial on which the drug got approved for genotype 1A and 1B, and you can see 97 to 99% cure rates. With the second study, these are people who actually had cirrhosis, and both were treatment naive and treatment experienced. Genotype 1A is the first bar, and then essentially comparing 12 to 24-week regimen, and you see that 12 and 24 weeks, the response rates are virtually identical. Thus, 12 weeks is all you need for this. And these are data for genotype 1B cirrhotics. Again, no ribavirin. So this is just these 4 drugs, all compensated cirrhotics, and you can see 100% sustained virologic response. So even when patients have progressed to cirrhosis, as long as they have not decompensated, you can still treat the virus and knock the virus out, which slows down the progression of the cirrhosis to liver failure, reduces the risk of liver cancer, but does not make it go to 0. So these cirrhotic patients still need to be screened for hepatocellular cancer. But it does slow it down. And of course, once you've cured it, the likelihood of it coming back after transplant, if they do need a transplant, is vanishingly small. There are some side effects associated with this. There is now an FDA letter. There have been about 26 cases reported worldwide as of a few weeks ago. And 10 of these were hepatic failures resulting in transplantation or death, and 16 with the liver dysfunction which reversed after stopping this drug. And most of it appears to be associated with Decompensated, and the liver injury developed within 1 to 4 weeks of starting the drug. And so in certain patient populations, such as those who already have decompensated cirrhosis, this is contraindicated. You don't want to use this combination. And the transaminase elevations did not appear to be a predominant presentation. So the bilirubin, they just got jaundiced, but their liver enzymes didn't really go up, and that's the pattern that was reported. So for Vicara PAC, which is the name by which this goes, word of caution, if people already have advanced cirrhosis with some features of liver failure, probably not a good idea to use it. Genotype 1A, you will also need ribavirin. Other combinations that are out there that are also used, this is Symptomatic, which is a protease inhibitor, and Sofosbuvir. So this is protease and NS5B. Remember 3 targets, protease, NS5A, NS5B. So these are 2 of the 3. And this is approved for genotype 1 by the FDA, and the practice guidelines based on level 1 evidence, again, treatment naive and experienced genotype 1 patients. And here's the data again. These are people who actually are either previously treatment naive or what we call null responders. These are people who got interferon-based therapy and their virus count did not budge. They had absolutely 0 response. So you can see over here this combination, 90% cure rates in that population. In the Optimus trial, you have to love these names. The Optimus trials, again, those even without ribavirin, just Symptomatic and Sofosbuvir, 97% cure rates. And at 8 weeks, this was about 83%. So probably 12 weeks is the optimal time regimen. And you can see once again that the response rates are pretty high. I'll draw your attention to the last bar, which is a little bit lower than the rest. And that is a combination with genotype 1A, where they had this mutation called the Q80K mutation. And if you do not use ribavirin in this, the response rate is only 74%. So it is currently recommended that people who have previously failed, who have genotype 1A, you should get this mutation, and these are commercially available. You can order it. And if they have it, then you need a ribavirin-based regimen. And essentially, here's Symptomatic and Sofosbuvir, again showing the impact of the Q80K and showing that by adding ribavirin, you can actually bump up the response rate. And the 1A without the ribavirin, you have the 74% response rate. So again, the practice guidelines recommend Q80K testing, particularly for 1A cirrhotic patients. Another combination that is approved is declarazvir and sofosbuvir. So this is declarazvir is ASVIR, so it's NS5A, and sofosbuvir is NS5B. And so this is approved for genotype 3. ASLD, there's evidence that it works for genotype 1, 2, and 3. It is benefit, of course, is this is pan-genotypic, so you don't really have to worry about what genotype the patient has. Just give it to them, they'll all get better. So there's flexibility in dosing, but the limitation is because it's very expensive, there's issues about access outside of genotype 3. Many insurance companies will not approve this right off the bat for outside of genotype 3 because FDA has only approved it for genotype 3 so far. And here's the data that this is declarazvir and sofosbuvir. Treatment-naive patients, these are people, many of these patients previously had failed protease inhibitors, PEG, interferon, ribavirin, and they got declarazvir and sofosbuvir with or without ribavirin. And you can see just declarazvir and sofosbuvir, 100% cure rate, 95% with ribavirin, almost the same. But it shows that ribavirin is really not needed in this population. What about those who are co-infected with HIV? Once again, you see this is an open label study, multiple genotypes, and essentially they got declarazvir, sofosbuvir for 12 weeks, 8 or 12 weeks. And so if you see those who are treatment naive, previously had not been treated, 96% response. Those who are with 8 weeks, the response rate is significantly lower in the HIV. So you need 12 weeks for the HIV population if you're going to use this regimen. And then those who are treatment experienced, against with 12-week, 98% cure rate. So a few words about NS5A resistance, because now we made so much progress with these NS5A drugs, NS5B drugs, the protease inhibitors. Protease inhibitor resistance, as I've shown you, pretty much can be overcome by the NS5A, 5B combinations. But what happens with this NS5A resistance? So there are several regimens that have been now shown to overcome the NS5A, and I shared with you the ledipasvir, sofosbuvir data. Declarazvir, which sofosbuvir also works, and then Vicirapac also has been shown to overcome the NS5A resistance. The current recommendation is if you do have any of these and you have an NS5A resistant viral sequence, and you have those unfortunate 1 or 2% who actually have treatment failure. If you have minimal liver disease, if you don't have much scar tissue, sit tight. A lot of people are working on this. New treatments are coming. Hepatitis C progresses over 10 to 20 years. Nothing's going to happen in the next couple of years if you have very minimal disease right now. If you have cirrhosis and you're all worried about this patient, you can potentially tailor the regimen after doing an extensive resistance sequencing for protease and NS5A inhibitors. Treat longer, consider adding ribavirin. So genotype 3, so much of this has been focused on genotype 1, which is 80% of all the patients that we have in the United States. Genotype 2, very easy to treat, 90 to 100% cure rates with just about any of the regimens, so very easy. Genotype 3 has historically been tough to treat. And so again, for genotype 3, we have a couple of years ago, the recommendation was sofosbuvir, pegylated interferon, ribavirin, still recommended. And now sofosbuvir plus ribavirin is being recommended as an alternate regimen, and declarazvir and sofosbuvir. So there are 3 possible choices for genotype 3, which was a difficult to treat genotype. So here are the data for sofosbuvir and ribavirin, which led to its FDA approval. Those who were previously treatment naive, with or without cirrhosis, you got 92 to 93% SVR. But those who were previously treatment experienced, those who had failed previous regimens, whether they're interferon-based or with protease inhibitors, essentially the response rate dropped, particularly if you were cirrhotics. So, there was a time where a 60% response rate would have been fantastic, but now we're spoiled. If it's not 90% or higher, we're not happy. So So still, this is suboptimal for those who are cirrhotic, for the treatment-experienced patients. So there's another study over here for treatment-experienced patients. This is very, very hot off the press data, only presented in a meeting, not yet in a publication. And this is called the Genotype 3, again, BOSON study. So these companies, they love these neutrons, bosons, positrons, et cetera. On the left are data for people who are treatment naive. On the right are data for people who are treatment experienced. For treatment naive, as you can see, progressive improvement in response rate from soft ribavirin for 16 weeks, 24 weeks, and then when you add pegylated interferon in this genotype 3, you get 95% cure rates. If you're treatment experienced, once again, if you look at the red bar at the right, which is sofosbuvir plus PEG plus ribavirin, you can get a 91% response rate. So it's not all bad. Sofosbuvir alone didn't do that much, along with ribavirin. But if you go to sofosbuvir, interferon, and ribavirin, so there's still a potential role for interferon in this small subset of patients, treatment-experienced genotype 3 patients. What about declarisvir and sofosbuvir? That was the third regimen that I showed you that the FDA has approved. And so this is a genotype 3, again, treatment-naive and experienced patients. They got 60 milligrams declarisvir, 400 milligrams sofosbuvir, 12 weeks. And you can see in the absence of cirrhosis, about 94 to 97%. But if you're cirrhotic, response rate drops again into the 50 to 60%. So again, you need that interferon ribavirin if you can tolerate it in the cirrhotic population. This is another study looking at 12 versus 16 weeks for genotype 3. Here only about 72% of these patients, subset of these patients actually had cirrhosis. And you can see again that the response rate, this is very early data, that even in the cirrhotic population, at 4 weeks from end of treatment, so it's SVR4, still not enough to really call it. This was just presented 4 weeks ago at the National Liver Meeting. 83 to 94% in the cirrhotic, and we'll see if this holds all the way out to 12 weeks. And those who had bridging fibrosis or cirrhosis, 100% end of treatment response. So we'll see if this holds. So the practice guidelines continue to evolve, and for genotype 3, again, there are many permutations and combinations. What I would recommend is not, the point of this table is to show that it's complex. There are many permutations available. And so personally, again, when I have a patient who is genotype 3, depending on whether they're cirrhotic, they're not cirrhotic, they previously received treatment, they didn't receive treatment, how they tolerated treatment in the past, et cetera, I go to the practice guideline and see what is the most recent current practice guideline. Because this is the ASLD website, this hcvguidelines.org, this is updated literally weekly as new data comes in. So it really stays. This is a phenomenal instrument and a practice tool that, at least as a hepatologist, I use. It's one of the few tools I actually use pretty much on a daily basis. So what's coming in 2016? Couple of new combinations. One is a protease NS5A, Grazoprevir and elbasvir. And another one, which is sofosbuvir and an NS5A inhibitor, ledipasvir. So Grazoprevir and elbasvir, this is, again, Previr and Asvir, protease and polymerase. It's been submitted to FDA. We expect FDA to give some pronouncement in January. That's the date, January 28th. And these are the data that have been submitted. So this is the EDGE study. These are treatment-naive genotypes 1, 4, and 6, about 22% cirrhotics. And what we see here is that the SVR12, 92% for genotype 1A, 99% for 1B, 100% for 4, 80% for genotype 6, and for cirrhotic patients, 97%. So, and it's a fixed dose combination with 100 milligrams of Grazoprevir and 50 milligrams of elbasvir in a single pill. So again, very, very exciting. We're continuing to try to shorten the course of treatment. This is Grazoprevir and elbasvir, again, the same study, looking at with and without baseline resistance-associated virions. If you do have resistance-associated virions, the response in 1A, as you can see, is pretty low. So it may not be good for that subset of patients. If you don't have those, 99% response rate. This is particularly, I think, interesting that this combination has been used in people with end-stage kidney disease because it does not accumulate and does not produce any side effects, even in people with advanced renal insufficiency. In this study, 75% of these patients were on hemodialysis, and all these patients had CKD 4 or 5, and you got a 94 out of 122 patients, 94% cure rate without any major serious drug-associated adverse events. Again, very, very recent data just presented at the European meetings a few months ago, not yet fully published. This is the other combination that has been submitted in October, so I guess it's 6 months from this that we'll know whether it is accepted or not. And this is the data. It's from the set of studies from Gilead called Astral. And once again, pan-genotypic, genotype 1, 2, 4, 5, 6. And it's a fixed combination of Sofosbuvir and elbasvir. So if you look at the data, about 10 to 25%, somewhere in the range, cirrhotic patients, about 19.4 overall at the left. And if you look at the SVR12, overall 99% sustained virologic response. For genotype 1, it's 98.5, genotype 2, 100%, genotype 4, 100%, genotype 5, 97%, genotype 6, 100%. So it's pretty dramatic. This is Astral 2, which is genotype 2 patients, both treatment naive and experienced. And you can see, once again, 94, 99%. This is a different study, cure rate. This is Astral 3, looking at genotype 3, and you can see 95% with Sofosbuvir and elbasvir. And if you look at Sof and ribavirin, which is the current FDA-approved regimen, that was 80%. Finish up with people with advanced disease. Even when cirrhosis decompensates, you can treat these patients, and this is a study of people with genotype 1 and 4, Child-Pugh B and C cirrhotics. So these are people who've actually got liver failure, and they got ledipasvir, Sofosbuvir, and then ribavirin as tolerated. And you can see over here between 87 and 90% sustained virologic response, even in these patients, based on 12 to 24 weeks. And the 12 and the 24 weeks didn't really look that different. So 12 weeks of treatment is probably more than enough. And this is published very recently in Gastroenterology. But what does this do to the patient? If you've already decompensated, is it too late? Is it even worth treating? Well, one reason to treat is to get the patient ready for transplant so that the virus doesn't recur post-transplant. And what we see here is what happens to the MELD score, which is a function of how well the liver is working, post-treatment. And you'll see that if you look at the distribution for Child-Pugh B treated for 12 weeks, Child-Pugh B 24 weeks, Child-Pugh C 12 weeks and 24 weeks, you can see half the patients, their MELD scores decrease, which means their liver function is getting better. But there's a subset of patients who continue to have progressive liver failure. So there may be a critical threshold where you cannot salvage the patient. This is where hepatitis C is different from hepatitis B, because even with decompensated disease with hepatitis B, if you put them on antiviral, dramatic response in terms of liver function, you can bring them back to compensation. Hep C, half the patients continue to progress once you start treatment after liver failure has set in. And post-transplant, again, this is a study called the SOLAR study, 223 patients, genotype 1 and 4, ledipasvir, Sofosbuvir for 12 or 24 weeks. And once again, you see 96 to 100% sustained virologic response. The child-PU C patients had a lower response rate. So, some of these patients actually had recurrent hepatitis C and already progressed to child-PU C. So again, if you got liver failure, the response rate, they don't tolerate, there's a compliance issue. They don't tolerate therapy that well, especially post-transplant. But post-transplant, before cirrhosis develops, if you treat it, you can essentially get 96 to 98% cure rates. So the question comes up that we are now trying to deal with is, when you have someone with decompensated cirrhosis, is there a threshold where you cannot avoid a transplant? And should some of these patients essentially just wait and get their transplant? And because we know we can have a 80 to 100%, 90 to 100% cure rate post-transplant, just cure them. It also opens the possibility that some of these patients may be able to take hepatitis C positive organs. One of the big problems, with transplant is the shortage of organs. And we threw away a lot of organs that were hepatitis C positive in the past. So if you have a hepatitis C positive organ that is otherwise intact, this is particularly true for kidneys, we would not use them. But now we're beginning to take kidneys as well as livers because after you transplant them, you can treat them for 8 weeks and cure them. So this is dramatically going to alter the wait time. Particularly for kidney transplants, wait times have melted down from years down to months by being able to accept some hepatitis C positive kidneys. So I'll end by saying that the current regimens are effective for most patients. Genotype 3, there's still some nuances. You have to watch out if you're going to use if the genotype, particularly for genotype 1A, the NS5A RAVs are worth checking for. And just be cognizant that there are rare, but there is a possibility of toxicity, particularly with the Vicera pack, where some liver toxicity has been reported, and the bradycardia with the Sofosbuvir. There are new regimens coming. The bar continues to get raised. And I think pretty soon we'll be able to cure just about everybody. Thank you.
All right. Questions? Got about 10 minutes. Yes, Dr. Strange. Oh, no, I'm sorry. You look like Dr. Strange. Wait till you see Dr. Strange.
Okay, great. Okay. Thank you. I've had a patient I've tried to get approved, I sent her to a GI specialist, and she's had trouble getting it paid for. It's about $100,000, is that right?
It has really dropped. That is where things started a while back. And access to care has become such a public health issue, and there's been so much debate about it. Many of the large pharmacies have negotiated with these companies. So the real cost is actually substantially lower. Now, they keep it very close to their vest, so they don't really share that with everybody. But it has dropped. My understanding is that the true cost based on these large pharmas have really dropped way down. In Virginia, about a year and a half ago, access to care was a real pain in the neck. You had to fill out a huge amount of paperwork and keep at it. But it has really become easier. Initially, we were only getting approval for the cirrhotic patients, but now we're getting approval for everybody. So for us, the problem has been because we have such a backlog. We don't have enough providers to, our rate limiting step has moved from the insurance to having enough hands on deck to monitor these patients through treatment. But it varies by state. It varies by state. And some states require some proof that the patient is not actively using drugs, et cetera, et cetera. So I think most gastroenterologists who are doing a lot of hepatitis C treatment sort of know what needs to be done to get if you have gastroenterologists who are treating only 1 or 2 patients a year or a handful, they may not know all the tricks of the trade to get it approved.
I'm starting to see some folks that are coming in now on some of these treatments. And I had a gentleman come last week whose pharmacist suggested we discuss the other medications he was taking in terms of the drug-drug interactions. You touched on a couple of different things. This particular gentleman was a diabetic on the sulfonylurea, also on an alpha blocker for prostatism, starting the Vicara pack. And you know, of course, you plug anything in the drug interactions, and you get all of these different alerts. Sometimes, you know, we don't worry so much about some of these things, where other times we maybe should take more pause. What are your thoughts in terms of concern about drug-drug interactions for some of these patients that are coming into us?
So this is much less of an issue than it was a couple of years ago with the Boceprevir and the Telaprevirs, which affected the CYP3A, the drug metabolism pathway. Most of these, other than the LFT abnormalities and the amiodarone toxicity, most of these I think we can manage. We just have to monitor the patient, and considering the treatment is only for 8 to 12 weeks, for most of these, it has really not been a huge issue.
So
The good news is that as opposed to 6 months to a year of treatment, the treatment's now 8 to 12 weeks for the 90% of patients.
So
So it has really been less of an issue.
you didn't get to it, but you probably will when you discuss abnormal LFTs. So how do we distinguish today the cirrhotics from the non-cirrhotics? Is there an indication for liver biopsy? Is it fibroscan? What are we doing to know that?
So that's, I think, an important question. When you detect somebody with hepatitis C, one of the things that you got to ask yourself, or actually not just hepatitis C, any kind of chronic liver disease, you got to ask yourself, is there underlying significant fibrosis that is currently being missed? And there are two ways you can do it. The cheap and dirty way is to look at something called the FIB4. If you Google FIB4, it'll just show you it's based on age, AST, ALT, and platelets, and it gives you a number. If it's less than 1.45, the likelihood of having any fibrosis is very, very low. The positive predictive value for excluding fibrosis is over 90%. If your FIB4 is over 3, very high probability of having cirrhosis, and then you have stuff in the middle. That's something, if you have a hepatic mantle and a platelet count, you should be able to figure out. FibroScan is getting more and more accepted, and FibroScan is, as you know, it's based on the concept of transient elastography, where you have pulses of ultrasound wave that go through the liver, and what you are measuring is really the speed at which the wave goes through the liver. And so the stiffer the liver, the faster the wave goes across it. So by measuring the speed at which it goes, you get a measure of the elasticity of the liver, which is a function of the amount of scarring in the liver. So if you have a FibroScan liver stiffness measurement of less than 5 to 6 kilopascals, you have no fibrosis. If it is more than 13 or 14, you probably have cirrhosis. And in between, you probably have some degree of scarring in the liver. So both FibroScan and the FIB4 have really sort of taken off and are widely available now. There are over 250 FibroScans in the US. So I think...
Would the presence of cirrhosis on a FibroScan push you in one direction versus another for treatment, or just to tell the patient that the cure rate will be less?
Well, the treatment, I think now that our regimens, it's become less nuanced, both the regimens work in cirrhotic patients. If the patient already has some clinical features of decompensation, I will avoid the Vicara pack because of the risk of toxicity. I would go with a Sofosbuvir, ledipasvir regimen. So the treatment decisions really not impact, but what it tells you is that this person already got advanced disease. You probably want to get on to treating them sooner rather than later. Do not postpone treatment. And if you're cirrhotic, then you got to have endoscopy to look for varices. You got to have the ultrasound to look for screening for hepatocellular carcinoma at least 12-month intervals. And you got to get your pneumococcal vaccine and all the usual stuff.
Other questions? It is interesting at the VA now, the VA is paying for FibroScans, the VA is paying for Hep C treatment. And each patient's an individual patient depending on their genotype and all, but I've seen a number of people come through my trials that, are being treated at the VA, so
Yeah,
it's
I-
cost effective for
Yes,
sure.
it's very, and I think there are now very good economic models that show that if you treat early, you reduce the burden of cirrhosis. And because right now, bulk of our liver-related healthcare dollars are expended on people who have already progressed to cirrhosis. And because the liver is such a forgiving organ, it doesn't tell the patient something is wrong till something is very advanced. It's like hypertension. You find out when you got a stroke, but that's too late. It's the same concept in the liver. You can't wait till you have your variceal bleed or a liver cancer to say, oh my God, I got liver disease. So we have to identify these patients in primary care.
Yeah.
And so you have to have a low threshold for thinking about it, risk factors, screening, ask about alcohol consumption. Prevention is always better. And then early detection and treatment reduces the burden of cirrhosis. So ultimately, you reduce the cost.
So
Now,
after-
of course, perversely, the pharmaceutical companies use that argument to put a $100,000 price tag on the drug. And we can argue about that. But the real problem has been when we've gone from our professional, from ASLD, et cetera, to insurance companies to try and get more access to care, is that the average American keeps their health insurance for 2 to 3 years. And since the benefits are going to be accrued in 8 to 10 or 15 years, many of them are saying, oh, wait, we're not going to benefit from this. Somebody else is going to benefit from this. So again, that's a complex problem to deal with.
So once you cure them, do they need surveillance for the rest of their life for liver cancer?
Only if they're cirrhotic. If you do not have cirrhosis, there is currently no recommendation, even if you don't treat them, for liver cancer screening, because for hepatitis C, virtually 99.999% of cancers occur in the context of cirrhosis. This is different from B, where it occurs without cirrhosis, different from NASH and fatty liver disease, where it can occur without cirrhosis. So C, it almost invariably occurs with cirrhosis. In cirrhosis, even when you cure them, the risk of liver cancer does not disappear, does not go to zero. It goes down, but it does not go to zero. So you have to continue to screen them.
And when do you see the day when the primary care clinician will treat this without referring it to a gastroenterologist or hepatologist?
So this is our hope, because there will never be enough hepatologists in the United States. We are turning out 15 to 20 hepatologists annually for a country of 300 million people. And even if we quadrupled this, we would not have enough hepatologists to treat every patient with hepatitis C. So our ultimate vision, this is from a different, using my ASLD leadership hat, is our ultimate goal is that the first line treatment, really, this is a primary care disease, has to be treated in a primary care setting. The hepatologist should see the few treatment failures, or those who have comorbidities, those who have progressed to cirrhosis, are complicated, side effect management, et cetera. So we view this, that would be in the domain of the hepatologist down the road. So we hope that in the next 10 years that we can, increase enough awareness of the disease first in primary care setting, and then be able to bring in enough primary care physicians and make them comfortable enough that they can start treating on their own, because that's the ultimate goal.
So
Because
to know someone's cured, the RNA level goes to,
zero, undetectable, with the most sensitive, PCR, quantitative PCR tool that you have.